we've been helping people see better since 1945. We employ more than 20,000 associates in 74 countries, supplying medical professionals who treat patients in over 140 countries. We are Alcon. We are there. We make a difference, helping the world look, see, and feel better. And after our first 70 years, we are just getting started. We are Alcon.
For your next cataract procedure, you're invited to the ultimate experience of control and clarity. The Clareon IOL with the Autonomy Delivery System. Autonomy is the first and only automated, disposable preloaded IOL delivery system. With its innovative CO2-powered delivery mechanism, Autonomy brings the predictable precision of automation to every delivery of the Clareon aspheric IOL. The device takes just 3 steps to prepare. Fill the device with an Alcon qualified viscoelastic. Remove the lockout assembly and use your thumb to advance the plunger and fold the IOL up to the pause location. Once the lens is in the pause location, confirm that the lens is properly folded and deliver it within 1 minute. The ergonomic design fits comfortably in your hand for intuitive control of the device during delivery, while the responsive speed control lever enables easy, single-handed control of IOL advancement. With its proprietary depth guard, Autonomy protects incisions as small as 2.2 millimeters. During delivery, you can vary the plunger speed at any time by adjusting the pressure on the speed control lever. Simply press the lever with your index finger to advance the plunger and deliver the IOL, ensuring that the leading haptic is properly placed within the eye as you implant the lens. It's that easy to deliver the Clareon IOL, a lens with a new hydrophobic acrylic biomaterial of unsurpassed clarity. Built with the exceptional bio-optics and biomechanics of Alcon IOLs, Clareon features an advanced IOL design with a fully usable 6mm aspheric optic dedicated to sharp, crisp vision from edge to edge. Produced with an advanced manufacturing process, Clareon also features a precision edge design. This design includes a proprietary edge curvature that reduces edge glare, as well as a continuous posterior barrier that guards against PCO and minimizes ND-YAG procedures. Stable force haptics give Clareon exceptional axial stability across a range of capsule sizes, with minimal axial shift and maximum refractive predictability. With its ultra-smooth optic, Clareon delivers unsurpassed clarity from the start, with among the lowest level of surface haze. And with its new microvacuole-resistant hydrophobic acrylic biomaterial, Clareon delivers unsurpassed clarity that lasts. This is a truly pristine premium IOL, delivered with easy, intuitive control. Together, Clareon Autonomy is the ultimate IOL delivery experience.
Hello there! Here are some important reminders for all you contact lens users out there. The most important thing to remember when using contact lenses is hand hygiene. Remember, wash your hands when putting on and removing your contact lenses. This is to prevent transmission of organisms that may cause eye infections. Do not rinse your lenses with tap water since it is not sterile and may have bacteria in it. Instead, use dedicated or proper contact lens disinfecting solutions to clean your lenses. Keep your contact lenses in a clean case filled with disinfecting solution when not in use. Remember to throw out used solution before you replace it with a fresh batch. Do not mix the old and fresh solutions to prevent contamination.
Make sure to keep the solution sterile and avoid transferring them to other bottles. Finally, always remove your contact lenses before sleeping or when going for a swim. Lastly, if you think you have infected or inflamed eyes, dry eyes, do not wear your contact lenses and head to your nearest ophthalmologist. With good eye hygiene, complications such as pain, redness, infections, and decreased vision can be avoided. Contact lenses can be very convenient and can provide its users confidence and great satisfaction when used properly. That's all for today. Enjoy using your contact lenses.
We help make a difference every day. We are a company driven by new discoveries and possibilities. We've been helping people see better since 1945. We employ more than 20,000 associates in 74 countries, supplying medical professionals who treat patients in over 140 countries. We are Alcon. We are there. We make a difference, helping the world look, see, and feel better. And after our first 70 years, we are just getting started. We are Alcon.
For your next cataract procedure, you're invited to the ultimate experience of control and clarity. The Clareon IOL with the Autonomy Delivery System. Autonomy is the first and only automated, disposable preloaded IOL delivery system. With its innovative CO2-powered delivery mechanism, Autonomy brings the predictable precision of automation to every delivery of the Clareon aspheric IOL. The device takes just 3 steps to prepare. Fill the device with an Alcon qualified viscoelastic. Remove the lockout assembly and use your thumb to advance the plunger and fold the IOL up to the pause location. Once the lens is in the pause location, confirm that the lens is properly folded and deliver it within 1 minute. The ergonomic design fits comfortably in your hand for intuitive control of the device during delivery, while the responsive speed control lever enables easy, single-handed control of IOL advancement. With its proprietary depth guard, autonomy protects incisions as small as 2.2 millimeters. During delivery, you can vary the plunger speed at any time by adjusting the pressure on the speed control lever. Simply press the lever with your index finger to advance the plunger and deliver the IOL, ensuring that the leading haptic is properly placed within the eye as you implant the lens. It's that easy to deliver the Clareon IOL, a lens with a new hydrophobic acrylic biomaterial of unsurpassed clarity. Built with the exceptional bio-optics and biomechanics of Alcon IOLs, Clareon features an advanced IOL design with a fully usable 6mm aspheric optic dedicated to sharp, crisp vision from edge to edge. Produced with an advanced manufacturing process, Clareon also features a precision edge design. This design includes a proprietary edge curvature that reduces edge glare, as well as a continuous posterior barrier that guards against PCO and minimizes ND-YAG procedures. Stable force haptics give Clareon exceptional axial stability across a range of capsule sizes, with minimal axial shift and maximum refractive predictability. With its ultra-smooth optic, Clareon delivers unsurpassed clarity from the start, with among the lowest level of surface haze. And with its new microvacuole-resistant hydrophobic acrylic biomaterial, Clareon delivers unsurpassed clarity that lasts. This is a truly pristine premium IOL, delivered with easy, intuitive control. Together, Clareon Autonomy is the ultimate IOL delivery experience.
Hello there! Here are some important reminders for all you contact lens users out there. The most important thing to remember when using contact lenses is hand hygiene. Remember, wash your hands when putting on and removing your contact lenses. This is to prevent transmission of organisms that may cause eye infections. Do not rinse your lenses with tap water since it is not sterile and may have bacteria in it. Instead, use dedicated or proper contact lens disinfecting solutions to clean your lenses. Keep your contact lenses in a clean case filled with disinfecting solution when not in use. Remember to throw out used solution before you replace it with a fresh batch. Do not mix the old and fresh solutions to prevent contamination.
Make sure to keep the solution sterile and avoid transferring them to other bottles. Finally, always remove your contact lenses before sleeping or when going for a swim. Lastly, if you think you have infected or inflamed eyes, dry eyes, do not wear your contact lenses and head to your nearest ophthalmologist. With good eye hygiene, complications such as pain, redness, infections, and decreased vision can be avoided. Contact lenses can be very convenient and can provide its users confidence and great satisfaction when used properly. That is all for today. Enjoy using your contact lenses.
We help make a difference every day. We are a company driven by new discoveries and possibilities. We've been helping people see better since 1945. We employ more than 20,000 associates in 74 countries, supplying medical professionals who treat patients in over 140 countries. We are Alcon. we are there. We make a difference, helping the world look, see, and feel better. And after our first 70 years, we are just getting started. We are Alcon.
Good afternoon, everyone. Welcome to today's episode, Attack on Cataract, a front-to-back approach to phacoemulsification. I am Ellen C., and I am one of your hosts for today. Together with me is one of the newest members of the Eye and Vision Institute, Dr. Nico Rogelio. Welcome, Nico.
Thank you, ma'am. It feels good to finally be here on TMC EyeTV's virtual stage, and I am as excited as you guys are for today's series of talks. So, join us in listening to the head of the Cataract section, Dr. Sidney Cheng, for his short welcome message.
Afternoon. As we try to adjust to the new normal, it is important to continue the process of learning and honing our skills in cataract surgery. We are proud to present to you another episode of TMC EyeTV entitled Attack on Cataract, a front and back approach to phacoemulsification. In the next few minutes, we hope to show you different innovations and new techniques in phaco. We will discuss different aspects, modifications, and developments from a holistic approach. From the front, we will see the advantages and benefits of the 2.2mm incision, as well as the features of the new Alcon active Sentry system. From the back, we will be launching our new plana vitrectomy training laboratory to help ophthalmologists in responding to complications that may arise during cataract surgery. As the head of the Medical City Eye and Vision Institute's Cataract section, and on behalf of our chairman, Dr. Vic Caparas, I would like to extend my gratitude in advance to our speakers, Drs. Richard Ko, Dr. Lisa Yu Mateo, and to our sponsor Alcon, and to our organizers for putting together this session with one of the most novel and practical topics for discussion. I am certain that in today's episode, we will bring together the minds of cataract surgeons, both young and old. I hope that you find this episode of EyeTV useful in your continuous desire to improve your craft. Thank you, and may you all have a nice day.
Thank you, Sydney. Through the years, we have seen the advent of novel and useful techniques and equipment for the improvement of what we call our bread and butter, cataract surgery. With all these advancements, we are now able to offer the best services we can offer our patients.
That's right, ma'am. This afternoon, we are lucky to have this opportunity to not only learn from our colleagues, but more so to learn about new techniques for our practice. In collaboration with our industry partner, Alcon, we will have two talks from two of the best cataract surgeons in the country.
Our first speaker is a good friend and a fellow refractive specialist, Dr. Annalisa Yumateo. Lisa obtained her medical degree at the University of Philippines, Manila, and finished her ophthalmology residency training at the Philippine General Hospital, where she served as a chief resident. She finished her fellowship in cornea and refractive surgery at the University of California, Los Angeles, Jules Stein Eye Institute, and the Singapore National Eye Center. She's currently the chair of Rizal Medical Center Department of Ophthalmology and also an assistant at the Medical City and at the American Eye Center. Let me now give the floor to Lisa as she talks about the 2.2 microincision and its advantages.
Okay. Good evening, everyone. I'd like to thank the Medical City Eye and Vision Institute and Alcon Philippines for this invitation to give the talk. Next slide. This is my financial disclosure. Next, please. And an outline of my talk. Next. So as you know, in this day and age, cataract surgery is considered a form of refractive surgery already. Next. So our main goal is to give the patient the best visual outcome that we can deliver. Next. So why is it important to make a good incision? 1, to prevent excessive leakage during surgery, thus creating a safer and more controlled surgery. 2, to prevent iris prolapse. And 3, to prevent infection post-operatively. Next. So these are the factors to consider when choosing a phaco size. How well does the incision seal and heal? What is the astigmatic consideration of the incision? How does it affect phacofluidics? And is there an IOL that will fit through the incision? Next. So during last year's PAO Virtual Congress, there was an informal survey on incision size. 172 respondents said they still use a 2.75 millimeter incision, while only 26 said they use a 2.2 millimeter incision. Next. So these are the aspects of clear cornea incision, and I will go over each one. Next. For location, technically this may be placed anywhere: temporal, superior, nasal, and even on the steepest meridian. The location influences the astigmatism due to the incision's relative distance to the visual axis. Next. So for architecture, this actually refers to the number of incision planes used in creating the wound. There are usually 2 types of clear cornea incision: the uniplanar, which we commonly use, this is the one without the initial groove, and the multiplanar, wherein a person or a doctor makes the initial groove incision vertically. Next. So shape, the goal is really to create a squarish wound configuration which will have greater stability than a rectangular one. Next. So for size, we'll talk first about the width. When I first started learning phacoemulsification in the 1990s, we started actually with a 3.2 millimeter incision. Then over the years, it went down to 3, 2.75, 2.2, and now it's even possible to do phaco with a 1.8 millimeter incision. Nevertheless, the width should have the following characteristics pa rin. It should allow easy entry and ease of mobility of the phaco tip, minimize incision leak while during the surgery, prevent incision burn, and allow insertion of the IOL. Next. So if you have an incision that is too small or tight, irrigation flow is decreased, the anterior chamber tends to shallow, and heat may build up causing wound burn. If it's too large or wide, excessive fluid egress will cause anterior chamber shallowing and iris prolapse. Next. So for length of corneal tunnel, the recommended length is about 2 millimeters. If it's too short, meaning less than 1.75 millimeter, the incision tends to be leaky and seal more poorly, and the iris will prolapse easily. However, the good side is that it may confer less astigmatism. If it's too long, it will restrict movement of the phaco tip, compromising visualization because of corneal distortion in the forms of radial folds, and it will also have more astigmatism. Next. So the following generally induces greater astigmatism: a bigger width incision, a longer tunnel length, superior incision over temporal, corneal incision over scleral, a uniplanar incision over multiplanar, and of course, tight suturing of your incision. Next. So what are the advantages of smaller incisions? Next. So let us review surgically induced astigmatism. Over the past several years, we've been hearing a lot about it. No? This is actually one of the factors that affect an optimal refractive outcome. This is important, especially if you are implanting a toric or multifocal IOLs. As you know, no, clear cornea incisions cause flattening of the meridian and stiffening of the meridian 90 degrees away, no? And this is known as the coupling effect. Ideally, each MD should generate his or her own SIA value. On the ASCRS website, no, there is an online tool there that you can access that will help you calculate your SIA. Okay, next slide. So this table is courtesy of Dr. Kondalwal and Dr. Montes de Oca. This table lists the studies comparing wound size to surgically induced astigmatism. And as you can see from the various studies, no, the larger the incision, the higher the mean SIA. And the smaller the SIA, just remember, no, the smaller the SIA, the earlier the refraction will stabilize. Okay, next. So in terms of phlacofluidics, with smaller incisions, there is usually decrease in flow due to the smaller caliber of the phaco-tip and sleeve, and this is called Poiseuille's law. The smaller amount of fluid going into the eye will mean lesser post-op inflammation. Next. So another advantage would be the shape. Now, it's much easier to create a square or near square wound configuration, which will have greater stability, meaning there's less hypotony and wound leakage than a rectangular one. Imagine trying to make a square incision with a 2.8 or even like a 3.0 millimeter width. What happens is, as you try to do phaco, no, there will be corneal distortions because the length is too big. And based on a study by Dr. Ernest, no, a square incision, regardless of actual width, no, will still be more resistant to deformation even with eye rubbing or squeezing post-operatively. And Dr. Berdal, in his study, said that spontaneous wound leakage was seen in 1 out of 5 cadaver eyes with the 2.75 millimeter incision, but none in the 2.2 millimeter incisions. Again, lesser wound leaks translates into a decrease in the risk of endophthalmitis. Next. There may also potentially be less dry eyes after a small incision surgery. As you know, the long ciliary nerves of cranial nerve V1 enter the limbus at 3 and 9 o'clock. And your cataract incision may disrupt these stromal nerves at the periphery, causing a decrease in corneal sensation and imbalance of tear film homeostasis. And this condition can last as long as 3 months. So you end up with medyo unhappy patients. The smaller the incision, the less disruption of corneal nerves and its accompanying neurotrophic or dry eye effects. There may also be less foreign body sensation over incision site post-operatively if the incision is smaller. Next. Currently, we live in difficult times and we always worry about AGP or aerosol generating procedures. Dr. Darcy's group reported that there was constant aerosol generation during phaco with a 2.75 millimeter tip, but there was none with the 2.2 millimeter tip unless the phaco tip was moved backwards towards the corneal incision. Shetty, on the other hand, found no visible aerosol generation during standard phaco, regardless of the incision width. However, realistically speaking, the risk of infection from phacoemulsification is very low. Aqueous is completely replaced by BSS when you start doing phaco, and when you put topical betadine drops on the ocular surface preoperatively, no, that already eliminates the virus because betadine is a very potent antiviral agent. Next slide. So I'll just show a few meta-analysis that compares the results of various sizes of incisions. Next. So this is a Cochrane review consisting of 26 RCTs. No? They have two groups, the C-mix, which is coaxial microincision cataract surgery group versus standard phaco group. The results showed that there is less SIA in the mixed group at 3 months. Both groups achieved similar BCVA, and there is little or no difference in endothelial cell loss and corneal thickness between the two groups. Next. The studies also showed little or no difference in intra-op parameters such as cumulative dissipated energy, BSSU, surgical time, and phaco time. And there was no difference in adverse events between the two groups. Okay, next. So their conclusion, no, C-mix is associated with less astigmatism than standard phaco, but the difference is actually very small. In most of the studies, no, safety outcome and quality of life were not adequately reported. Okay, next. This is another meta-analysis, no, done by a Chinese group consisting of 15 RCTs. No. They again have two groups, the coaxial standard incision cataract surgery and then the coaxial microincision cataract surgery. In terms of intra-op outcomes, no, there was no statistically significant difference between the two groups when you look at mean surgery time, BSSUs, effective phaco time, and CDE. However, the C6 group, no, required a shorter ultrasound time than the mixed group. Next. And they actually said in their discussion, they said that having a longer ultrasound time does not necessarily mean there is more of ultrasound energy being delivered in the anterior chamber because each machines, no, may deliver different amounts of ultrasound energy. Okay, next. So pooled results on best corrected visual acuity showed no significant difference between the two. There's also no significant difference in terms of laser flare photometry values, which gauges the cells and flare and inflammation post-op. In terms of endothelial cell loss, there was initially no significant difference between the two at day 1 and day 30. However, from day 60 and beyond, no, the C-mix group showed greater endothelial cell loss. They think that with the older machines, the smaller phaco tip used caused a bit more turbulence, and also maybe the longer ultrasound time resulted in the said greater endothelial cell loss. Again, in terms of astigmatism, no, goes without saying, mix showed less astigmatism than the standard phaco at day 7 and day 30. Okay, next. So their conclusion, no, the two procedures still are very comparable to each other. C-mix may have longer ultrasound time and greater endothelial cell loss. And on the other hand, mix is more advantageous in terms of SIA. They also said towards the end that this may not be applicable anymore as the technology for phaco machine continuously improves. Okay, next. This is the last meta-analysis I'll be showing, no, consisting of 11 RCTs. Again, the two groups being compared is similar. No? When it comes to effective phaco time, corneal thickness, endothelial cell count, and endothelial cell loss, no, the two groups are pretty much the same. What is statistically different is the average ultrasound power, which is lower in mix, and the astigmatism, which is also lower in mix. Next. So their conclusion is there is short-term and long-term decrease in astigmatism in mix, and there is really no difference in safety outcomes or in the time required for surgery between the two groups. Next. So next question is, how do you transition from a 2.75 millimeter incision to a 2.2 millimeter incision? Next. Overall, there is really no major change and no learning curve. It's just important to use the correct size keratome. One thing I remember when we were transitioning is that you may need to have a thinner capsulorhexis forceps, and you may need to regrasp the capsule more frequently because your movements as you turn around doing the rhexis may be limited by the smaller incision. But in the end, no, sanayan lang naman yan. Next. Use also the appropriate sleeve for the phaco and the IA tip. Most companies have color-coded their tips and sleeves to make it easier to identify. Generally speaking, there is usually no need to change your phaco parameters, but if you want to be more conservative in the beginning, you can always lower your settings by maybe 10-20% and then adjust accordingly. Okay, next. Newer phaco machines have really been optimized. They already have enhanced tubing, improved vacuum pump, sophisticated software that balance the fluid settings. Just remember with mix, less fluid does pass through the eye, so the procedure is going to be gentler on the ocular tissues. Okay, next. Alcon has made it easier because they have a complete system, and it's the Alcon microcoaxial system. It consists of a 2.2 keratome knife. And for those still using the Infinity, they have the Intrepid FMS pack, which has a more rigid tubing that decreases post-occlusion surge. For those using Centurion, they have the active fluidics, which have plates inside the machine that compress the BSS bottle very fluidly. And for IOL insertion, they have the Monarch 3 inserter, which is color blue, plus the D cartridge, which can be used up to 27 diopter IOLs. So this whole system makes it very easy to transition from a 2.75 to a 2.2 millimeter incision. Okay, next. Okay, that ends my talk. Thank you very much.
The Centurion Vision System has redefined phacoemulsification performance, making every moment of cataract removal better. With the introduction of the active Sentry handpiece, Alcon is introducing a new standard of safety to your operating room. Its innovative design is the first of its kind to move the fluidics pressure sensor from the console to the handpiece, delivering unprecedented responsiveness, consistent IOP, which you select, and increased safety in every moment. The active Sentry handpiece reacts in real time to changes in the anterior chamber, communicating with upgraded Centurion Vision System hardware and software to quickly mitigate occlusion break surge. The system detects occlusion and signals for a pressure adjustment to the BSS bag. When occlusion break occurs, quick valve technology releases fluid into the aspiration line, actively reducing surge and dynamically maintaining target IOP. The pressure sensor's advantageous placement in the active Sentry handpiece also allows for quick detection and compensation for incision leakage. A signal from the compression plate prompts the Centurion Vision System software to adjust pressure to account for leaks and properly maintain target IOP. The active Sentry handpiece automatically detects patient eye level relative to the Centurion Vision System's fluidics management system during phaco. The pressure sensor in the handpiece drives active irrigation, making automatic adjustments to maintain target pressure at any eye level, helping make cases more consistent. Alcon is committed to helping you advance cataract procedures and outcomes through partnerships and innovation. That's why we've engineered a handpiece designed for dynamic responsiveness and increased stability across procedures. The Centurion Vision System with active Sentry handpiece is designed to set a new standard of safety for every phaco procedure.
Thank you, Ma'am Lisa, for that great lecture. It's amazing how these small changes in our technique can actually make big differences on the outcome. We have just started, guys, and there's definitely more for this episode. For now, I would like to remind our viewers to fill out the attendance form that will be posted towards the end of this episode. And as always, you may post your questions at the comment section below. Before we proceed, please watch this short video from our sponsor, Alcon.
Welcome to the Alcon Experience Academy, your one-stop resource for training, product information, and much more. The Alcon Experience Academy is a great resource for any healthcare professional who engages with the eye, including ophthalmologists, optometrists, nurses, technicians, and students. If staying up to date on products, services, techniques, and training taught by professionals from around the world is important to you, the Alcon Experience Academy should be your go-to source. Let's take a look. This scrolling banner will immediately let you know what's new. Content of interest can be customized by you to show the latest content based on your personal preferences, whether by an area of focus or by specific topics of interest. This engaging content comes from some of the leading specialists from around the world. Recently added content will show the newest resources added to the site, allowing you to explore some of the latest innovations in eye care. My Courses is where you will find courses for your specific needs. It also shows the courses you have taken and completed and those courses you are still in the process of completing. In addition to other helpful tools, additional resources will point you to more than 100 informative FAQ videos on Alcon technology. My Events shows you a calendar of the upcoming webinars or face-to-face training events that you've signed up to attend. Now let's take a look at some features of the Alcon Experience Academy. Accessibility. Gain access to the content you need when you need it. The mobile-friendly format allows you to access content on the go. Usability. Ease of use on every step of your informational journey. Navigation. Move easily from one topic to the next, from one piece of content to the next. Searchability. Find what you need fast. Trackability. Keep track of the modules you've completed, ones you still need to complete, and exactly where you are in the modules you've started. Robust content. Over 500 training videos, with additional content being added all the time. Getting started is easy. Simply register at alconexperienceacademy.com and gain access to all of this content today.
Thank you, Alcon, for this opportunity to partner with you in promoting better surgical approaches. Let us move a step further and discover how the active Sentry system will change the dynamics of our surgeries, as it promises a more stable intraocular environment and avoids instability at any point in the procedure. Nico, would you do the honors of introducing our next speaker?
Of course. Our next speaker will give us a quick review of phacoemulsification, which is a crucial concept to grasp when performing phacoemulsification. In relation to this, he will also introduce us to the Alcon Active Sentry system. We are honored to have today as our lecturer one of our former hosts here at TMC EyeTV, Dr. Richard Go. Sir Rich is a graduate of the University of the Philippines, Manila, Medicine, and finished his ophthalmology residency training at the Philippine General Hospital, Manila, where he likewise served as chief resident. He finished his fellowship in neuro-ophthalmology at University of California, Los Angeles, Jules Stein Eye Institute. Currently, he is an active consultant at Medical City, Philippine General Hospital, and American Eye Center. Let me turn you over to Dr. Ko.
Good afternoon. So thank you to the EyeTV team for inviting me back. It's always a pleasure to participate in this platform. I'm actually pre-recording this in advance in anticipation of internet issues next week during the actual episode. So let me just share my screen. And okay, I'm gonna start with this quick financial disclosure slide. So I was asked to talk about my brief and humble experience with the Active Sentry, which is an upgrade in the Centurion Vision system. Now, I want to start with this disclaimer. I always mention this to residents. Honestly, today, 4th and 5th generation phaco machines all have excellent fluidics, allowing you, the surgeon, to focus more on the surgery and pay little attention to the machine's fluidics. And in fact, I admit that as surgeons, we have been paying less and less attention to phaco-dynamics and fluidics as a topic of discussion in the last few years. Now, compared to 20, 25 years ago when half the topics in conferences were on phaco-dynamics. This is really a testament to how good our phaco machines are today. In fact, about a decade ago, I thought we had reached the upper limit of phaco technology, hence the transition to femtosecond surgery, but that's another story. But then once in a while, a machine comes along with a new innovation, setting it apart and just a little bit ahead of everyone else. I'm talking about Centurion's active fluidics, which for the very first time did away with the gravity-based fluidics, which is still a limitation of most phaco machines today. And to appreciate what active fluidics and active Sentry entail, let's have a brief crash course on phaco-dynamics. Not extensive, just a quick review. These are excerpts from the basic course in phaco that we hold in my university, PJH, every year for the past 15 years. We'll start by looking at it from a historical perspective, again, so we may appreciate what active fluidics and active Sentry really entail. Then we'll try to end by looking at some cases we recently performed using this phaco system. So again, it's always nice to start by looking back where we came from. Now, honestly, the first generation phaco machine, we've had this technology for more than 50 years now, but the first generation machines were not so good. The chamber was very unstable. You have to have a good grasp of fluidics and phaco-dynamics. And over many conferences and over many bottles of beer, we had these discussions on these settings. And of course, a lot of these machines were limited by gravity. Mga usapang lasing, we had many discussions about this, whether it was better phaco-dynamically to use a glass source or a plastic source. And if you were to use a plastic source, whether it was phaco-dynamically better if you put a vent or not. These were many discussions over beer. We were so OC about setting the patient's eye level. We had to make sure it was eye level with the machine, with the cassette, and with the patient's head. And once in a while, this happened. The ORs 20 years ago, some of the ORs back then, the ceilings were not so high. So this was not an uncommon incident back then. So these were all our discussions. Now consider this. Consider this. The first live human patient by Dr. Kellman was a patient with a blind, painful eye. And this was his exact description. Strong surge of the suction caused the cornea to collapse 30 to 40 times during the 70-minute phaco. 30 to 40 times. Today, if we have one episode of anterior chamber collapse during surgery, some of us lose it in the OR. We blame the nurse, we blame the assist, we blame the technician, we blame the machine. But at that time, the chamber collapsed 30 to 40 times. Of course, the eye was a bag of pus that had to be removed the next day. So Dr. Kellman, he spent the next 2 years trying to figure out how to prevent collapse. And he realized that this was, he needed a valve for this. So the speed of the current in the aspiration line exceeded the speed of the irrigation. This valve opened to halt suction. Now, little did he know, this moment may have been the birth of modern phaco-dynamics. And the rest is history, really. This was really a crucial stage in the development of phaco-dynamics. So fast forward 50 years later, as I mentioned, phaco machines of today, all are very good, and excellent fluidics, stable chambers. Usually they're all controlled by advanced computer chips and sensors. So that's 50 years later for you. So let's talk about the basic setup. In any phaco setup, there's a fluid source, there's a phaco handpiece, and there has to be a mechanism to draw fluid out, whether this was a pump or a vacuum. We know that these are two types of pump system, peristaltic systems, very common in training institutions. It's really good for beginning phaco surgeons. It's nice, it's slow, and it's easy. In contrast to vacuum pumps, no, seen in your Venturi system, usually preferred by advanced, very fast surgeons. Now, this can be a little dangerous. No? Acts like really like a vacuum cleaner. No? You can suck out many intraocular structures. No? For example, an overeager resident trainee. Now, in the peristaltic system, there's a drum that rotates, and this creates boluses of fluid that draws fluid out. No? Now, what's very, very important in peristaltic systems is this, no? That your vacuum rises only when your tip is occluded or partially occluded. And this is frequently a rookie mistake. No? You don't get a rise in your vacuum because you don't have tip occlusion. In contrast to Venturi systems, as we said, it acts like a vacuum cleaner. You point, you shoot. More pedal action results in more vacuum. Now, I always ask this of first-year residents. No? Do you agree with this statement? The key point in fluid dynamics is that the inflow should be equal to outflow. And usually half of the audience will agree with this. And this is really wrong. No? Because the key in phaco-dynamics is the inflow should always exceed the outflow. No? And this is what really determines chamber stability, you know, in any phaco system, that the inflow should always be more than your outflow. And there are many other sources of chamber instability. You know, for example, limitations to your inflow, the wound size, for example, the compliance of the eye. These are things that can limit your inflow. Now, with aspiration, with occlusion, there's flow interruption, and with occlusion break, there's flow resumption. Now, this side-by-side comparison of a novice and an expert just shows you that sometimes the leakage from the side port can be significant during surgery. As you can see, there's a lot more significant leakage from that novice surgeon compared to the expert surgeon. Let's do away with all of this. I actually want to focus on that last item only, surge, you know, a post-occlusion phenomenon. Let's talk about surge for a while. But a little sidebar before we go into that. In a peristaltic system, when the tip is fully occluded and there's no leakage occurring, little math, bottle height of 75 centimeters of water will translate to 750 millimeters of water divided by the relative weight of mercury. This will result in an IOP of 55. Which means if you have a bottle height of 150 centimeters, which was, you know, we used to do that 20 years ago, you will have an IOP of 110 when the tip is fully occluded. So this slide is just to remind everyone using a peristaltic system, be extremely cautious about utilizing bottle heights that exceed 100 centimeters. No? As this level can result in pressure spike, you're already venturing on retinal artery pressures. No? So just be careful with that. No? I know some of the surgeons in the audience are now thinking, what's my bottle height in my last OR? Think about it. I actually did the math for you. In the last surgery that you did, if your bottle height was 100 centimeters, your IOP 73.5. Your bottle height was 90, 66. For those who exceed bottle heights of 100, again, if your bottle is 110, that's an IOP of 80. Again, you're already venturing on retinal artery pressure territories. So just a little sidebar. Now, let's talk about post-occlusion surge. Now, try to imagine this. When you have a chunk at the tip, no, and you have occlusion, you hear this ding, ding, ding sound, no, because vacuum is being built up. Try to imagine what is happening in the aspiration line. While you're hearing that ding, 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 the aspiration line is actually being compressed, no, because of the negative pressure that builds up. Now, as soon as occlusion is cleared, no, either you're able to eat up the chunk or the chunk gets disenlarged, no, flow resumes, and you have that sudden expansion. That's this post-occlusion surge. No? And actually, every phaco company is looking at this. They're trying to make this as small and as shallow as possible, no? This post-occlusion dip. So, the next, as I mentioned, the next generation phaco machine, they're all working on this post-occlusion surge. Again, how do we make this shorter and shallower with the future iterations of our machines? No? And let me just give you some examples. We've mentioned this, the Centurion vision system. No? This was the very first machine that did away with gravity-based system. No? Active fluidics, you have a BSS bag being compressed by two active plates. No? So with this, they were able to do away with gravity. And because of that, they're able to make that post-occlusion surge dip a little bit more gentle compared to infinity. And remember what I mentioned earlier, imagine the aspiration line, what's happening, it's being compressed. No? if you try to look at the aspiration line of the Centurion system, you try to compress, it's actually nearly impossible to compress that. No? So it doesn't really contract and expand a lot, making your fluidics very, very stable. So another example is this, Brand Z. We won't mention the brand. No? They have this software system that they call the surge protection. Basically, what it does is this. No? They actually put an attachment in the BSS bottle. I call this the Frankenstein attachment because they pressurize the BSS bottle. And in doing so, they're able to achieve a target IOP without raising the bottle. No? So it actually simulates active. Is it active fluidics? No, but it comes very, very close to active fluidics. And again, everybody's goal is really to make this post-occlusion dip as shallow and as short as possible. So, evolution of technology in phaco. In the 90s, we had gravity-based. In 2000, we had pressurized fluidics. And in 2012, active fluidics was introduced. So what was next? Now, the Centurion was launched in 2013. And I remember in one of the conferences we had about 8 years ago, the speakers were being asked if they had a wish list for how to improve this machine. And I remember saying at that time that it's an excellent machine, but if I have one criticism, it's this one. Is that the IOP you're showing is not a true IOP because you really don't have a manometer inside the eyeball. The signals would have to travel at the speed of sound, no, to the sensors which are located in the cassette. There's still a millisecond delay. So the IOP that you see is not really the IOP in real time. And I remember saying at that time that, you know, it would be nice if you could have the sensors closer to the eyeball, maybe in the handpiece. And, you know, 7 years later, that's exactly what they did. They put the sensors in the handpiece now, so that the IOP that they're measuring is now the real IOP, detects the IOP in real time. So it's really an improvement in the fluidics even more. So in doing that, they've done this. No, again, the goal is try to make that post-occlusion dip as gentle and as shallow as possible. And comparing the volume displacement with the Infinity and with the Centurion with active fluidics and the Centurion with the active Sentry, you see that the dip is really shortest and shallowest with the Centurion with the active Sentry. There are other features of this machine. No? They have this quick valve technology, which is a combination hardware software, again, making the fluidics even more stable. This is a nice addition. No? You don't have to adjust for the patient's eye level because the IOP measured is the real IOP all the time. So there's really no need for adjusting the patient's height. The table, the height of the machine, and it also now, again, compensates well for average incision leakage. No? And comparing the IOP, no? The one on the left is comparing it with the gravity fluidics, and the one on the right is comparing it with the pressurized fluidics. And as you can see, the IOP is really more stable with the active fluidics and active Sentry with the Centurion system. So let's just try to look at some cases. The machine was parked in our clinic for about 2 weeks. No, I was able to do some cases with that. Let's just try to look at some. These are mostly uneventful and routine cases, no, different types of cataracts and different densities. I really apologize. We do not have a video overlay. We had some problems syncing the machines, and in the end, we did not have any overlay. So I just took a snapshot of the screen and to show you the IOP that I was using. So let's look at that first case. The first thing you will notice really when you use the Centurion system is that the chamber is really very stable. No? You don't see a lot of these chunks flying around. No? Just here I'm doing a dry chop, dry pothole chop. As you can see, the chamber is just very stable. And I used an IOP of 50. This is the first time I used an IOP below 55. Now, we've used the Centurion for a while, and we've actually set our IOP steady at 55 now. So this was the first time I went below 55 at 50, just trying it out. And again, the whole time it was very, very stable. The one on the upper right is a denser cataract, no? An N05. I make my pothole a little bigger, becomes a crater. Then I do a combined stop and chop. Let's just turn on the other videos here, the one on the left. And Lower left and lower right, these are more cortical types. Again, I just want you to pay attention to how stable the chamber is, with the different types of cataracts and different densities. Just all very, very stable. Let me just fast forward some of the videos here. Again, very, very stable chambers. Okay. So these are, uneventful cases. Really, nothing much happened with these cases. So let's look at other cases. This case, this patient actually she was scheduled for surgery 2 days before that. She had an acute attack with her IOPs going above 60s. We were able to control the IOP medically, and the next day went in and did the surgery. Now, ordinarily, the concern here was that the cornea might still be a little hazy. And it was actually a little hazy before we started. And the worry is that during surgery, it will haze even more. So I said, let's drop the IOP at 40. This was the first time I was doing surgery with a Centurion using an IOP of 40. I've never gone this low. But for this particular case with a potentially compromised cornea, that's what we did. And again, from start to finish, the cornea just remained clear. You see some zonulisis there with the capsule. But again, from start to finish, the cornea just remained very, very clear. Let's look at some other cases. A high myop. I have another sidebar here. Again, those who attend the basic course, you're familiar with this. I talk about LIDRS seen in high myopes. American Eye Center has a lot of these cases. And it's one of those instances where if you know the maneuver, it's so simple. But if you don't know about this can take 1 hour of surgery and you will not finish this. So you know that the maneuver for this is to lift the iris. Try to equalize the pressure below the iris and above the iris. As you can see here, you see that LIDRS. I come in with a side port, chopper, I lift the iris, and boom, pressure is equalized. However, this particular maneuver will still take maybe 3 to 5 seconds for you to accomplish. And in some patients with severe LIDRS, this can be really, really bad. I'll show you a case, which I did 15 years ago. This was an autistic 55-year-old male. The mistake was to do this under local. I talked to him. He said he could do it. But he had severe LIDRs. Notice, every time I came in, patient would quite literally jump, move his head, wanting to stand up, really squeezing. It was very, very difficult. Put anesthetic there, that's useless for LIDRs. Again, this was 15 years ago. I pre-placed my chopper so that I can do that, and yet there's still 2 or 3 seconds before you're able to initiate that maneuver. The patient will still feel that pain. And again, it can be really, really bad in some cases. I will never forget this case 15 years ago. There, I'm able to lift the iris and equalize. It's better for the patient. But again, later on, even for INA, I go in, LIDRS, the patient would just squeeze. Okay. So this was really a bad case. That was 15 years ago. The answer to this is actually this. This was presented by Dr. J. Vicencio in a joint ASCRS, PSCRS in San Diego back in 2007, which is this. You pre-place an iris hook and you totally prevent LIDRS from happening. Unfortunately, this was presented in 2007. The bad case I had was 15 years ago. We didn't know about that maneuver back then. Anyway, I mentioned LIDRS because for the last 7 years that we've been using the Centurion active fluidics, I've been seeing less and less LIDRS over the years. Maybe because gravity is now irrelevant. It's still there, because you still pressurize the eyeball. But I think I'm seeing it less and less over the years. So this was a high myop. I expect LIDRS in this patient, and yet, from start of the surgery all the way to the end, hardly any LIDRS in this patient. Let me just fast. So here I worked at an IOP of 50. Let me just fast forward this. So here we are with epinucleus, cortex. After which I'll do INA. Again, anticipating LIDRS in this patient. I'm already warning the patient. You will feel this, but take a look. It's practically no LIDRS. That's what I'm saying. Since we've done away with gravity-based system, I think I'm seeing less and less LIDRS over the years. Same case with this, no? Axial length 29. I expected a lot of LIDRS in this patient, but from start of the surgery all the way to the end, there was hardly any LIDRS in this patient. Again, let me just fast forward this in the interest of time. So here I was working at an IOP of 44. Again, I was trying to put the IOP lower and lower and lower as much as I can. This was a polarish cataract. I tell my students to treat these cases as you would a polar cataract, no? Meaning take out the cataract and leave the epinucleus behind as a cushion. You want to remove this in toto at the very end once you already remove the nucleus, no? And the hope is that thick posterior subcapsular polarish plaque will already detach from that posterior capsule, no? And we know that that posterior capsule is quite fragile in these cases, no? Polar cataracts and very thick posterior subcapsular cataracts. So here I'm just staying in the end, no? I'm able to eat up the epinucleus, no? Usually at this point, especially in these cases, I would advise residents to put a spatula on the side port, no? The residents would call this the last chunk syndrome. Put a spatula underneath, to protect the PC. But here, I was very confident about the stability of the chamber, that I hardly did any special maneuvers to protect the PC, knowing that the PC is actually flattened out, and is not in any danger of actually suddenly going up and being accidentally hit by the phaco machine, by the phaco tip. So again, pretty stable chamber. Okay, so IOP here was at 40. Okay, interesting case. We did this patient. She had a 1X. You know what happens in these cases. You get this Argentinian flag sign. In the basic course, into my resident, there are maneuvers I teach them. Put viscoelastic. You want to flatten that capsule. You want to decompress with the needle. These are maneuvers to prevent the Argentinian flag sign. And yet, once in a while, it's still unpreventable, such as these cases. It's really, really intumescent, already predicting that this is going to rip. And true enough, it ripped. So don't panic. Reevaluate. You want to refashion your capsulorhexis, so you make another incision here. Notice here, again, because of the intumescence, I'm noticing that the capsule feels like it's going to run away. So again, we teach our residents, you stop. If you feel like it's going to extend, stop. Flatten that with viscoelastic and do this. I call this the rapid pull maneuver. You just flick your wrist, bring that capsule towards the center again. And here you're able to fashion a decent enough opening. But of course, your capsulorhexis is not continuous. So I said, let's bring down the IOP at 40. Because we don't have a complete capsulorhexis. I want very, very little tension on that capsule. And again, from start to finish, this was no problem at all doing this case. Again, notice how stable that chamber is. Hardly epinucleus and cortex. Again, usually I would advise my resident at this point, might be better to put a spatula in the side port underneath your phaco tip, just to protect that PC from being damaged in case you have that, again, what the residents would call the last chunk syndrome. But here, you notice, the chamber is very stable. I just stay in the center, step on step 3, and hardly any fear that that PC will be damaged. Okay, this is, I believe, the last case that we did. Very interesting case. She had corneal leucoma. We had to apply EDTA first to clear, and this was the clearest that her cornea was, so we decided to do the surgery. Specular count was 600, so I told them, bring down the IOP of 34. I was looking at the screen. I said, this is kind of scary. I've never done cataract surgery with this kind of IOP at 34. As I mentioned, my usual IOP for Centurion is 55. But they said, let's bring it down, protect that corneal endothelium. So we put iris hooks, do your continuous curvilinear capsulorhexis, do your hydrodissection. I advise doing a very good hydrodissection in this case to loosen up that nucleus from the bag. And for the phaco part, I basically just stayed in the center. I did a little pothole chop, but basically most of the time I was just there in the center, trying to do slow motion phaco. And here, epinucleus, cortex, and you're done. Again, let me just fast forward that a little. Okay, that's it. Last chunk. Okay. INA, again, the chamber was very stable during INA. And IOL insertion, we were even able to put in a toric IOL in this patient. One-eyed na lang, so we wanted everything for this patient. Day one, the cornea was just very clear. And after the surgery, I again looked back at this. I looked back at the screen and, it seems surreal looking at that IOP of 34, but it's really just so nice to do surgery at or very near the true physiologic IOP. It's just really awesome to do that. So anyway, in summary, really the new innovation for the Centurion system is the active Sentry, which with the sensors now in the handpiece, you're able to really do surgery closer to the true physiologic IOP of the eye. Now, again, just looking at that IOP 34, let's have a little fun with math. Just again, looking at that IOP of 34, what would be the theoretical bottle height equivalent of a gravity-based phaco system operating at an IOP of 34? Sige nga. Anyone? Residents? Anyway, converting that, reverse math of what we did earlier, you multiply that with the relative weight of mercury, you get a bottle height of 46. I don't think anybody here now today would do phaco surgery with a bottle height of 46. That's not 46, by the way, that's 90. This is 46. Again, I don't think anybody today would do phaco using this system with a bottle height of 46. And this is only possible because you're not using gravity-based system. Based on the Centurion's active fluidic, it's really possible to do surgery closer to the true IOP of the eyeball. And with that, I thank you. I'll be happy to answer your questions about the machine. And thank you and good afternoon to everyone.
Thank you for your comprehensive presentation, Rich. You always have this passion when talking about something you believe in. Let me just remind our audience to type in your questions at the comment section below, as we will be addressing each of them shortly.
I think we already have a couple of questions ready. Let me call back our two speakers on screen and let us begin with our first question. Okay, we'll just pull up the question. Okay, so our first question is, will the active Sentry handpiece work with a gravity pack as well?
That's an interesting question. I'm not sure with the active Sentry handpiece. Actually, when they first set it up in our clinic, I think 8 years ago, we actually started using the Centurion with the gravity based. And then later on that we use the active fluid. What I'm not sure is that if the active fluidics active Sentry will work with the new system. That's what I'm not sure about. We can ask the Alcon reps actually with that. But really, it's not really logical to be not using the system if you bought that machine and then use the gravity-based one. It doesn't really make sense.
Thank you, Sir Rich.
Do we have our second question? Do we have evidence of a lesser decrease in endothelial cell loss by using the new handpiece?
There are some, actually Alcon can provide you with those studies. They have some initial studies on that. I'm just not sure if they're published. Initial very low comparison of how low the endothelial cell damage is with the active fluidics and active Sentry. I just can't name the exact studies right now, but your Alcon reps will be happy to give you these studies.
Thank you, Sir Rich. Do we have more questions? Okay, our next question is, are there any potential advantages or disadvantages with using a 2 mm size if ever there was a need to convert the phaco into a PTCE?
Okay. Actually, for me, if ever you are really going to convert to ECCE, I would like suture my incision and then move superiorly and do the usual traditional na ECCE. I think that would be better than extending a corneal incision to on the temporal pa to a like a 5 mm, 6 mm length, and then you'd end up suturing it anyways. You know.
Yeah.
So
Actually, yung mga pag 2.2 and then you suddenly convert to ECC, we don't really need to suture that. Maybe if it's bigger than 2.2, 2.75 or 3.2, yun kailangan mo i-suture. But I've seen some rest of this conversion, lipat ka lang sa superior ECC, you don't really need to suture pagka 2.2. And that's another advantage.
Yeah, you probably have a point there. Siguro ako mas praning lang ako and I want a more stable. And then don't forget, a lot of the times they forget to inject fluid, make the eye firmer. Otherwise, it's so difficult to make a slot if it's too soft.
yeah. So the incision size doesn't really matter that much if we're converting to ECCE now.
Mhm.
So I think we have a next question. Would it be advisable for trainees to start with a 2.2 mm blade for the main incision?
For me, yes. I think it's okay for residents to start directly with a 2.2 as long as they have the proper system for it. Like their machines are capable of handling fluidics-wise a 2.2 incision. There's no really advantage in like a stepwise approach na do a 2.75 muna and then eventually transition to a 2.2.
Actually, in PGH, some of them still did the 275 kasi inuubos nila yung stocks ng blade. Marami pang stock. So, meron kayo nga, but they're not transitioning to 2.2.
Ibang story yan.
Ibang story na. Yung iba maraming inuubos nila yan.
So
But really,
for capsulorhexis,
as Lisa said, there's really no reason not to go 2.2 now. And for those who are worried about transitioning 275 to 2.2, really there's nothing to it, really, the transition. Promise.
so they won't have difficulty doing capsulorhexis, no? Even with the small incision. Yeah. Okay.
Sanayan lang talaga eh. So if you start learning that na you just go dire-diretso.
Tandaan mo lang, pag malaki incision mo, you can go this way. Pero pag maliit incision mo, you have to learn how to pivot in the wound para mas makakaganon yung flex. Yun lang yan. Tama si Lisa, sanayan lang sa pag-pivot ng kamay with a smaller incision.
And I've seen residents na parang very instinctive na parang they figure it out na how to move around.
Yeah. Speaking from experience, when I transitioned from 275 to 2.2, I think I just had to be extra cognizant of preparing the appropriate materials, especially with the injection of your IOL. You might be used to using a 2.75 injector, and then you'll be surprised when you're using when you transition or attempt the 2.2, you find yourself having to extend your slot because you didn't anticipate or it totally slipped your mind. So this just might be something that people will have to be more cognizant about with the transition.
Yeah.
Okay.
Do we have another question, Abby? Okay, so our last question is, would it be advisable for trainees to start with the active Sentry handpiece?
Yes, of course. Of course, definitely. Definitely.
Kaya lang baka ma-spoil sila. So sobrang stable nila. Pag lumipat sila.
Siguro, don't try very, very low IOPs muna. When you start at what you're used to, 45, 50, okay. And then later on you can, that's what I did pababa ng pababa. And actually, stable din talaga siya. But if you're worried about that, you can start with an IOP of 45 or 50. Okay siya.
So I think
Okay.
they're worried if they go to their practice and they don't have the machine, will they have a difficulty doing phaco with other machines if you're used to the active Sentry?
Not really.
No.
Like I said,
Okay.
if you can do phaco now, the fourth, fifth generation machines of every other company, quite stable. They're almost idiot-proof. No, the phaco machines of today are almost, I'd say, they're idiot-proof already.
Yeah.
Sobrang
I
ganda na ng
agree.
fluidics din.
Sobra, I think the technology has advanced leaps and bounds from when we were still starting.
There is another question. Do you need to change the irrigation factor when you're using a 2.2 incision?
No,
Parang ako rin.
not really.
Okay. Another question, I think, does post-occlusion surge occur in a Venturi system?
In theory, they will occur with all phaco machines. In theory.
Okay, so
Kahit
any
na gaano
system.
ka-sensitive lahat. Even the Centurion active fluidics active Sentry, I don't think you'll get rid of the post-occlusion surge. But really, the goal is to really minimize it as much as possible.
I think that covers all our... Oh, okay. So we have another question. Does the active Sentry system make use solely of a sensor on the phaco handpiece?
What did he mean by that? The active Sentry. Who asked the question? Is the question you're asking? Kung
I think it's related to the previous question. No.
Okay. Dr. Samson asked the question, sir.
Yeah, Del. Can you show the question again?
Okay, so there is an update to the question. So does the active Sentry system make use solely of a sensor on the phaco handpiece? Are there hardware, software, or faster CPU sampling upgrades?
Yun. Kaya kulang nga yung question. Meaning, hindi lang siya. As I mentioned earlier, there are other factors in the machine, no? Like there's a quick valve system, which is a combination of software and hardware that makes the chamber even more stable. Yung irrigation factor, side port leakage. So it's not just that one handpiece that's doing everything. It's really a combination of all of these small features that make the system very stable.
Okay.
I think that answers the question.
Yeah. Okay, I think we got all.
Alcon to demonstrate the machines in your hospitals. No? Alcon is just willing to demonstrate the machine. You really don't pay attention to what we're saying. Use the machine, try it out, so it can speak for itself, really.
Another question pala. Any personal tips to avoid post-operative corneal haze for hard cataract cases?
Viscoat, viscoat, viscoat. Those are the three things I will say. These are not the cases you scrimp viscoelastics on. No? Hindi pwede yung chaka gel, yung mga chaka gel nyo or the other 50 peso methyl cellulose, hindi talaga pwede. You know, it's not unusual pag very brunescent, 85-year-old, NO6, NO7. I won't mind using 2 or 3 whole vials of viscoat. No? I've done surgery on really compromised, cell count nearly 0. Every quadrant, I inject viscoelastic. Every quadrant, inject viscoelastic. Yun lang, that's... those of you who are frequently having corneal haze post-op, tignan nyo rin minsan na the way you do surgery because sometimes you're doing surgery, malapit lang yung phaco tip nyo sa endothelium. I see that sometimes with the beginners. Hindi nila alam, they did everything well, but upon review of the video, medyo tumataas-taas pala yun. Kaya it's important to video all your surgeries because you will notice things that you did not notice during surgery. I'm really an advocate of videoing all your surgical cases for review later.
And that brings us to our very last question. Would using continuous phaco settings lessen post-occlusion surge?
Can you flash the question? Medyo na. Can you flash the question?
Sir, it's also in the chat box, sir, if you there.
Ano na chat?
Would using continuous phaco setting lessen post-occlusion surge? I guess in comparison to a fixed setting, if I presume correctly.
I don't see the difference much with this. I don't know if you, the one who asked the question, notices this. I don't really notice this a lot.
Okay.
That's
all the questions already. Thank you everyone for your participation, but this isn't the end of the episode yet. As you all know, the Eye and Vision Institute has pioneered and promoted the utilization of the pars plana approach when doing anterior vitrectomy when the need arises during cataract surgery. With this, the Institute has decided to take it a step further by widening its reach in training not just its residents, but the consultants as well.
At this point, we have covered the front part of the program. You may be wondering what the back part of our episode is. If you can recall, one of the first few episodes of TMC EyeTV last year focused on pars plana anterior vitrectomy. In that episode, Drs. Arnold Salud, Rich Ko, and Cindy Cheng gave us a briefer on the said technique.
I do remember learning a lot from that episode. However, I also remember that one of the apprehensions that came up during that time was the lack of training and practice in actually inserting the trocar to perform the PPAV.
That's right, Nico. It is especially challenging for non-retina specialists to do this without the proper guidance. Because of this, the TMC EVI, together with Alcon, has come up with a PPAV training lab. Details on this will be released soon. For now, let us listen to one of TMC EVI's senior residents, Dr. Abby De Gia, to tell us more about her experience with PPAV.
A year ago, I found myself in a difficult situation. I was only in my 3rd month of performing phaco surgeries when I encountered my first complication. After what I thought had been a successful, uncomplicated removal of the nucleus, my heart sank as I saw strands of vitreous coming out of a tear in the posterior capsule. The situation became even scarier for me when my consultant suggested that instead of performing anterior vitrectomy using the already existing corneal incisions, I try doing so via the pars plana. With the knowledge I had from our lectures on pars plana anterior vitrectomy and under the guidance of my cataract consultant and retina fellow, I soon realized I had little to be afraid of, as the procedure went smoothly and ended successfully. No more vit in the AC, the IOL was safely implanted in the sulcus, trocar was removed, and the wound was tight and sealed. There are so many advantages of this method, and all it took was a little wisdom, a little guidance, and a little courage. So I hope you'll join us as the Eye and Vision Institute of the Medical City launches the first ever pars plana anterior vitrectomy training lab, where you'll realize, as much as I did back then, that the first trocar in is all it takes.
Thank you, Abby. That is such a great initiative, and I'm looking forward to the Institute's future endeavors. Thank you, everyone, for tuning in. I am very glad to have hosted this episode with you, Nico.
Likewise, ma'am. Again, do not forget to fill out the attendance and evaluation forms posted in the comment section. Before we end, I would like to thank all of you for this very informative episode, and we would like to thank our speakers for lending us their time and expertise. To get notified for new live videos through our YouTube channel, please do click on the subscribe button below. Again, I am Nico Rogelio.
And I am Ellen C. Watch out for our next episodes, only here at TMC EyeTV.
Ophthalmic Instruction Without Borders.